And our next speaker is Katriona Shea from Penn State, and she is Professor of Theoretical Applied Ecology, and she's going to talk to us about harnessing multiple models for outbreak management. Katriona, please.
Good morning, everybody from the East Coast of the United States. Can everyone see my slides okay? Hopefully. I would like to thank you all for the invitation to speak today, and I'm going to talk today about how we can actually use models instead of individual experts as the experts in an expert judgment process. And in particular, we're going to be focusing on how we deal with outbreak management in this context. And I'd like to acknowledge various funding sources and also an amazing team, including some experts on elicitation in that team. Now, as you have probably seen, there are a great many models floating around now for any epidemiological system, but particularly for COVID-19 at the moment. But any public health or livestock or wildlife health disease will often trigger multiple modeling efforts because these are significant and important challenges for human and health and welfare. Now, the problem is that even for diseases that have been circulating for very long periods of time, like measles or influenza, there's considerable uncertainty. With a disease like the coronavirus that we're dealing with at the moment, it's been around for less than a year. So of course, there's incredible amount of legitimate scientific uncertainty about what's going on. And this then immediately hampers modeling efforts and immediately hampers decision making. And so this is a simple cartoon of something that might come up in some situations. Here, there's a model consortium with 3 models, and you can imagine your 3 individual experts, and they've been asked to assess which of 3 interventions or actions are the best for managing this outbreak. And we do gain some information from this exercise. All 3 think that action 3 is terrible. And so you have learned some information, but it's very challenging for a policymaker who is not necessarily comfortable with models to decide whether action 1 or action 2 is best, if particularly in a case that I've seen where model 3 actually had a very good track record on a prior outbreak. So this one had tried and true information, but this one, there was some more consensus on what one should do, and it makes it very challenging for policymakers. So we have come up with an approach that is to try to harness the power of these multiple models addressing similar questions. And we draw on synthetic approaches that use ensemble averaging or super ensemble modeling, which you will be familiar with from climate projections and weather projections. So if you've ever seen hurricane tracks moving up the coast of the USA, those are dealt with in that way to come up with some sort of an ensemble. And similarly, these methods are also used in fisheries and now much more commonly in forecasting for epidemiological outcome. And so what they do is they take the outputs from multiple models and do statistical averaging in some way that's very similar to what you do with expert elicitation. In my opinion, though, the problem with that is that this is focused very much on what will happen, which is absolutely appropriate for something like weather, where we have little agency. But in the case of an outbreak, we have quite a lot of actions that are at our disposal, particularly with older diseases where there are vaccines, for example. And so we're focused not on what will happen, but what to do to make the problem as small as possible, however that is defined. And so we also then draw on a rich body of literature that was mentioned earlier, today by Professor Aspinall, for example, on risk analysis, decision theory, structured decision making in particular is what we use, which are formal tools for analyzing decisions. We focus a lot on the sort of decision making equivalent of a sensitivity analysis, which is to look at the values of information, which is understanding the importance of uncertainty specifically for a decision. And even sometimes we work into adaptive management processes where you're making repeated decisions in the face of uncertainty so that you take management actions, but with a plan to learn about the system in a way that will help you to do better. And that's really essential in something like an outbreak, because as we know, we don't know everything and we need to plan to learn and yet manage at the same time. And I can talk more about those methods if anyone is interested. So we have been pulling ideas together from multiple fields, including the field of expert elicitation and expert judgment. And we just had a policy forum paper in Science about harnessing multiple models for outbreak management. And what I'm going to do is talk you through this process. And we are actually right in the middle of running our first exercise now on reopening strategies. It's a slightly simplified approach, but the link is there if you're interested to have a look. Made in consultation with decision makers at the US CDC, the Centers for Disease Control, and other epidemiologists who have expertise in management. And I'm going to say that what we do is we draw together ideas from three fields. The first is the very important field of decision theory, and particularly decision making in the face of uncertainty. So that would include risk analysis and so forth. Then we build on this new interest, particularly in epidemiology, about multiple model projections. But instead of just saying, what do you think will happen? We actually say, what do you think will happen for specific objectives and for specific interventions? And it turns out that the objectives in question matter a great deal. So at first glance, you would say, well, the number of deaths will be correlated with the number of cases. And this will be true if you have 0 cases, you will have 0 deaths. But it turns out that because of age structure in susceptibility and particularly in terms of risk, you can have, for example, a very small outbreak in a retirement community that might have a very large number of deaths, versus a smaller outbreak, say in a university or a school setting, that might have very few deaths. So very precise definitions of objectives are essential, and then the interventions can be assessed. And then the third body that we draw on is the field that you actually know much more about than I do, which is the expert judgment and elicitation field. And in particular, we have drawn on the modified Delphi approaches that were mentioned just moments ago in the questions. So this is an overview. This is on the one side, you see the very detailed picture from Science, but it's because of their panel structure, it's very long and skinny, so it's a bit hard to see. So this is a simplified version. The problem at the top is that we have a coronavirus pandemic that is causing havoc worldwide. We then elicited objectives from decision makers, and I will discuss those in a moment. And we also looked at plausible and realistic interventions that could be conducted in those settings. We then come down into ask multiple models, and we've got something like 35 models that have signed up to do this exercise with us, though of course not everyone may submit. And here what we do is we ask all of the groups to do what you do with expert elicitation, which is do an independent assessment of the objectives and interventions together. And the idea here is that the models are the expert's hypothesis or best estimate of what's going on in the world. But what then is important, based on both what Professor Aspinall and Professor Wilson just discussed, was that not only is there then parametric uncertainty built in, but also structural uncertainty, because some of the models are different. Some of them are just simple SEIR models with susceptible, exposed, infected, and recovered or removed, which includes dead. Others have much more complicated structure, including age structure, structure by gender, structure by race, or may include, for example, key uncertainties. For example, we know very little about the proportions of cases that are pre or asymptomatic, and these are really important and critical uncertainties. Similarly, there may be parametric uncertainty, for example, about the waning of immunity. If immunity wanes the way it does with the common cold, we have a very different problem than if you have acute immunizing an infection like measles, where you can never get it again. The dynamics will be vastly different, but it's only been around for about 6 months, so we don't know. Okay, so these are legitimate sources of uncertainty. So then after the independent model projections, we have a feedback and structured group discussion that's scheduled for 24th of June, just so you know. And then we will ask the groups to update their projections. And so during that discussion, we will first of all discuss things like linguistic uncertainty about the objectives or interventions. We will discuss whether there are sources of information that may have come up that some groups are using and others are not aware of or haven't used. And we'll also look at all sorts of other types of possible uncertainties that might explain why projections disagree. So the Groups then will update their independent projections, but without a requirement for consensus. So this is really important. We do not require consensus. We want the full expression of uncertainty, so that when we do decision analysis with the risk, with risk assessment or value of information analyses, that the decision maker is fully aware of the breadth of uncertainty that pertains to the system. And then in the case of coronavirus, there is a very real possibility that we can implement the synthesized second round discussions, second round results, I beg your pardon, after the discussion, and actually get feedback on how the models have done if they match, say, real interventions that occur in the field. So there's a real possibility for either or both of passive and active adaptive management as updated information comes in. And there are some important steps here too, where as the experts work on these projections, they may clarify objectives, such as control is too imprecise, and in fact, cases or deaths may be a more precise wording, minimizing either. And they may also come up with suggestions for interventions that the decision maker did not originally consider, and that the whole group can then assess in a second round. So there may be actions that come out of this process that then feed back into policy. So we currently have the first elicitation exercise on post-lockdown strategies. We have 5 objectives that we've asked modelling groups to assess. The first is to minimise cases, then minimise deaths, minimise peak hospitalisations, minimise the probability of a new outbreak, and minimise the number of days workplaces are closed, which is somewhat economic, towards the economic end of the objectives. And then we've got 4 interventions that we've asked the groups to assess. The first is full closure. The second is to reopen workplaces 2 weeks after the peak, reopening workplaces when cases are at 1% of peak, and immediately open all workplaces. And these 2 second and third of these interventions have some linguistic or semantic uncertainty that will be important for the group discussion to assess, but it reflects some of the guidance that particularly is happening in reopening guidance, for example, from the federal government in the USA. So this is ongoing at the moment. We have our first submissions due in the next few days. So our analyses, we plan to do aggregation methods that are used in expert elicitation exercises of the types that you've just discussed, so I will not go into them. We've requested 100 quantiles from each of the models for each of the objective intervention combinations, because they're models. I see Professor Aspinall waving his hands, but it's because these are models and they can actually come out with quantifiable metrics so that we can do all sorts of very cool analyses that you possibly cannot do. And remember, now we're taking into account both structural and parametric uncertainty by requesting information from models. So we've synthesized that, but we also have a checklist that allows us to drill down and say, well, did you include this or this, and see if there's anything that in later analyses allows us to explore why some models may agree or disagree. We'll also use value of information approaches. If we find that there's uncertainty but that it doesn't matter to the decision maker, there's no need for anything further. And the process is designed so that it can actually provide guidance to decision makers after the first round. So if there's really a rush, we can just use the first round results and make recommendations to the decision maker at that stage. So these are the approaches that we're planning, but as I told you, we're doing it right now. The paper just came out, we're running it right now. But I can show you some work that we have done in the past with 2 livestock disease and a disease, Ebola, that we're all familiar with, that give you the idea of what sort of other things we can do with this work. In particular, we did this, but we did it ourselves and it's way too slow, which is why we moved to looking at these expert elicitation methods, because now we've got 30, hopefully, but probably fewer because people will drop out, but some respectable number of expert models are running this process for us at the same time. So we could never have done that. If we had to do it ourselves, it would be a sequential process, we'd be far too slow. So we've been looking for ways to speed this up, and this is where the expert judgment literature has been so extremely helpful and beneficial. So here are some results from a close collaborator, Will Probert, who worked here with us at Penn State for a number of years. And he looked at this for a livestock disease. This is a cow that does not have foot and mouth disease, but I'm sure you remember the 2001 foot and mouth outbreak that shut down the UK for a chunk of time in 2001. Yep. And what we did was Will got 5 different modelling groups, very different models, models A, B, C, D, and E. These are anonymized to avoid any feedback stress, basically. And we looked at 7 different possible control strategies. And we also did this across some different objectives to make the point, or to clarify the point, that the objectives really do matter. Excuse me. So what you can see is blue is good. You know, there is a quite clear consensus, even across different objectives, that a relatively good action is this one. Doesn't matter what it is, but there is an action that's relatively good. But what it also illustrates is that there can be some quite strong disagreements. So these two, if you look at costs, can you see my cursor? I'm pointing with the cursor. Yes, thank goodness. All right, so under cost, you can see that there are 2 panels that have broad consensus that these are not bad at all. These are probably the best actions. But if you go to some of the worst actions, you can see some very strong disagreement. These 2 objectives have quite strong consensus that this is the worst. But if you care about minimizing the duration of the outbreak, excuse me again, then there's a very different action that's coming out as worst. So what this does is it fosters a discussion between modeling groups. Why did we disagree or not? So we didn't formally do this process for this exercise, but it also allows us to go back to the decision maker or the stakeholder and say, well, look, there's, you know, luckily here there's some consensus, but imagine that there wasn't. You could say, well, do you care more about the cost or the duration? And this is reflected, for example, in coronavirus right now, where opening up in the US is happening probably counter to public health, and it's a strong tension between the objective that's economic and the objective that's to do with minimizing deaths and cases. And that tension is what's driving a lot of the issues at the moment in at least the USA. Here's another example from a work by a former postdoc who's now professor in China, Dr. Sholi Li. And she looked at Ebola. And what happened was, when the Ebola outbreak happened, we identified something like 55 models that people were writing to and publishing to address the question of how big is this going to get? And the estimates from the published papers were all over the place. Some were down at 10,000 cases, others were up over 1.5 million cases. There's extreme disagreement from very, very respectable modeling groups about what would eventuate. We feel very strongly that perhaps that's a very good question, but an even better question is, what do we do to make it as small as possible? So I'm going to explain this panel, which summarizes the results from that work. What Dr. Li did, very painfully, was recoded 37 of the models and then simulated 10,000 people susceptible with a single case arriving, and said, how big does it get? And she structured this by the structure of the model. So some were just simple models, others included hospital or funeral stages. And what you can see is, look at this first pale panel under SCIR. You can get nearly everybody gets sick to nearly nobody gets sick. So huge disagreement about how big is this outbreak going to get that arises from these different models. And this variation is also observed in the other model structures. However, when you ask the models, what should you do to minimize the number of cases? And we looked at things like reducing funeral transmission, hospitalization, and so forth. You can see the ranking in here. Red is best. I'm sorry, it's not the same as in the previous slide. Red is best, and the paler ones are the worst. You see extreme consensus on the best actions to take, despite the fact that the size of the outbreak itself might be quite different. So that work then showed us that there were very good methods available, but it was, as I said, much, much, much too slow, which is what brought us to using the approach that I just discussed to you today. And so, of course, as we're doing it right at the moment, I cannot show you results, but we are hoping that it goes well, and that we will also then use this method to pull together all of the teams that are working worldwide, or as many as wish to participate, to look at future elicitations, in particular about governance levels. For example, should we be making these decisions according to WHO international guidelines, or at a federal, state level in the US, or at a county or a city level? And what is the best sort of governance level for which these decisions can be made? And there's a big body of literature, for example, in the economic literature on how those there are tensions between those different governance levels. We're looking at vaccine trial locations. There will be some vaccine trials coming online later in the year, but we need to know now where there'll be high incidence later in the year. So we need those forecasts to project high incidence areas. And we're also very interested in how we'll allocate testing during reopening in order to balance our ability to reopen. And so hopefully many more. Are we hoping these methods will gain wide traction? We'll see. We'd be naive to think that we won't be updating them. This is our first try, merging these 3 different areas. But just to mention, this is not restricted to epidemic management. It can be used for endemic disease, such as circulating disease like measles, flu, polio. We look for at eradication, but you could use it for any other type of decision-making process that involves multiple models, so economic decision-making processes and so forth. So there's many, many other places where this work could be of use. And so with that, I would be happy to take any questions. Here are some of my slides to remind you what I spoke about.
Great, thank you very much indeed, Katriona. Now I see on the chat we have a hand raised. Let me just, is that right? Was it Stephen Sparks? Are you there? But we can't, I don't think we can hear you. If you have a question, can you please put it on the Slido, because that's the only way we can see the questions. Right. So you said you want to present outputs from multiple models to show the range of uncertainty, but not all models will perhaps be equally reliable. And I wondered if there's a way in which you can adjust for that or tag them.
Yes, there is. So different decision-making agencies have different strategies. For example, the WHO relies only on 6 core models for its decision-making in this context. Other groups do different things. So it's possible to winnow it down. You could also request that you only use models that have come from a group that is well established. Certainly there will be models, like deterministic models will just have no expression of uncertainty that's of any utility in this setting and wouldn't be able to contribute. There are discussions about this. I mean, the sort of crowdsourcing projects suggest that actually, as was referred to in the first talk today from Professor Aspinall, that actually the wisdom of the crowds may come out as useful sometimes, but you know, the experts may not be the best. But in his case, they were the best. So you can train it on outcomes. And what's happening right now, because there's such a diversity of responses, particularly in the USA, with different states or counties opening or not opening, it will be possible to actually learn about what happened under different management actions. And if we can set up elicitations that are sort of fairly generic, then we can actually use that feedback from what actually happens to learn about which models are better. So initially we're weighting them all equally unless there's some very obvious flaw, but it's certainly possible for us to aggregate those with weighting and actually to change the weighting through time, which is partly what adaptive management is for.
Yeah, I think there was another question from Mark Bergman, and I think you've just answered it, but I will put it just in case we want to add. He says, your models are the experts. Are you planning to weight them based on performance? And I think
yes. So initially we won't. Initially, we're just making an initial decision. We'll provide decision makers with a round 1 decision, and we'll compare that ideally with the round 2 decision is what we should be doing, because by that, having that discussion, we're getting rid of sources of bias that are actually something we can learn about, including these linguistic sources, because some of the guidelines are quite fuzzy. But if we can then get feedback from the real data, yes, we will be able to do that, where we will weight them. And there's a bunch of the sort of ideas about how one would do that, and some quite different philosophies that have come up. And so we are looking at that. And what's really fun is if we get enough groups participating, we'd be able to partition them the way that the first talk did into experts and non-experts, and ask similar questions about did the experts do better or didn't they? Because in some contexts they don't, and in some contexts they do. And it'll be very useful. And then we can weight them for future rounds. And it may be that some models, models are built for purpose. So a given model may be excellent for one set of questions and actually perform poorly for another set of questions. So that is also something that we must be aware of. So the weighting will have to take that into consideration.
Okay, that's great, Katriona. Thank you so much.